Hi, John Kanelopoulos presenting on behalf of our group, George S. Malis, PhD, and myself from the LaserVision Clinical Research Institute in Athens, Greece. We're introducing here a new objective analysis of refractive surgery outcomes. We're trying to find from the difference maps, as you can see here in this initial presentation slide on the Pentacam before and after in a myopic LASIK correction, what was the actual effective centration and stratified in a large number of cases, and thus be able to compare two different lasers and the ability to center the ablations, not just as an aim, but as a result postoperatively. So we looked at a very large number of cases, 280 eyes that were treated for myopic LASIK, and we were able, by using our proprietary software and the difference maps that derives from the pre-op, as you can see on the bottom right on this slide, and the post-op, the difference map gives us the actual ablation performed, and that ablation is centered on the cornea apex where all these procedures were planned. And we're able to obtain cases from two different groups. Group A was our earlier experience with IQ 400 excimer laser by wavelight, and Group B were our more recent cases utilizing the EX 500 excimer laser by wavelight, both lasers by Alcon. So in Group A, the femto used was the Intralace FS60, and in Group B, the FS200. And as mentioned before, Group A cases were treated with the IQ 400 excimer laser and with an eye tracker frequency of 256 Hz and a calculated response time of 6 to 8 milliseconds, where in Group B the EX500 excimer laser and a tracker frequency of 1064 Hz and an estimated response time of 2 to 3 seconds. And on the image here you can see how we're able to, with digitizing this picture, to ascertain what was the deviation from centration from the cornea vertex, shown here in blue, as described by the Pentacam, the Seinfeld device, and the actual ablation performed as defined by the geometric center of the difference map before and after. The analysis for all the cases mentioned before gave us the horizontal and vertical displacement of the center of the ablation with respect to the corneal vertex, and in all cases, as mentioned before, an attempt was made intraoperatively to center on the cornea vertex, cornea apex, in simple words, the line of sight as best defined during the procedure. So we found that the IQ 400 Hz group had a mean 120 micron horizontal displacement and 360 micron vertical displacement on the right eye, and similar numbers on the left eye, where the EX500 laser was much better in both groups, with much smaller numbers, as you can see here on the table on the left. On the top table on the right, table 3, the radial and angular displacement of the center ablation with respect to cornea vertex is seen on top for Group A with the IQ laser, and on bottom on this table for the EX500 laser, showing again the very significant differences in micron, 360 microns on the IQ laser, and 120 microns on the EX500 laser in average. And then on the bottom table 2, the demographics between the two groups which were matched can be clearly seen. Again, here the results summarize the very big difference, which was statistically significant, and also on a histogram, the percentage of eyes that had displacement of 50 microns on the far left 100 microns on the next column. Blue is the IQ laser, red is the EX500 laser, 200 microns is next, 300 microns after that, and essentially the other bars have really no data from the EX500 laser, just data from the 400 IQ laser. I think very nicely illustrating the significant differences on the amount of actual displacement of the ablation in each laser, and also in box plots on the right side, these data also summarized and illustrated in a different way. Now we should note here that it has been shown that displacements anywhere over 200 microns of an excimer ablation will create significant coma. So both the lasers were able to employ the pupil centroid center in order to treat and center their ablations. The results of the study indicate that the EX500 laser in group B was extremely better in centering the ablation than the previous model, the 400 IQ laser. And we can only attribute these differences to improvements incorporated in software planning and a higher speed and shorter response time that the tracker has in the second laser, and maybe partly to the fact that the second laser is faster and less possible deviation from the patient within the same numbers of dioptric corrections placed is expected. So in conclusion, in this study we introduced a new objective technique away from what we have been used to seeing as far as visual outcomes, refraction, visual acuity, and contrastivity and wavefront data that may help the refractive surgeon with new standard metrics in refractive laser efficacy and efficiency. The displacement of the ablation pattern may depend on the laser platform, and the dramatic improvement in the efficacy of centration shown here with the newer generation wave-light laser has been attributed to the better eye tracking and shorter treatment time. Thank you very much.